Hello everyone, welcome back to Doctor's Desk. Today's lecture is on mechanical ventilatory support, one of the most important pillars of intensive care medicine. So I have made a concise PPT on it so that you don't get confused by seeing this long text of Harrison's. So yeah, let's get into it. So what is mechanical ventilation? It means delivering positive pressure breaths to a patient, either partially or completely replacing spontaneous breathing. So we initiate ventilation for three broad reasons: hypoxemic respiratory failure. Common examples are ARDS, severe pneumonia, pulmonary edema, and massive trauma. Then second one is hypercapnic respiratory failure. Examples are COPD exacerbations, then asthma crisis, then neuromuscular diseases. Then third reason is airway protection. What if impaired airway protection like coma, trauma, and other neuromuscular paralysis. So in these cases, ventilation is life saving. So before getting into it, we will see about the physiology. So normally our lungs inflate through negative pressure breathing. The diaphragm contracts and the chest wall expands, the intrapleural pressure falls, and the air is drawn into the lungs. So in mechanical ventilation works the opposite way by creating a positive pressure at the mouth and alveoli, forcing air into the lungs. So this change in mechanics has consequences. So the positive pressure can reduce venous return decrease and cardiac output, and it can alter the hemodynamics. The success of ventilation depends on three things. So it's lung compliance, airway resistance, and work of breathing. So before getting into the basic ventilator settings, we should also know about the dangers of the ventilation. So one of the greatest challenges in critical care is preventing the villi, which is ventilator-induced lung injury. So there are four major mechanics happening in villi, which is volutrauma, means over distension, then barotrauma, which is high pressure causing pneumothorax, then atelect trauma, repeated collapse and reopening of alveoli, then biotrauma, which is inflammatory mediators released due to mechanical stress, which can spread systemically and trigger multi-organ dysfunction. So clinically, villi worsens hypoxemia, creates a secondary ARDS-like picture, and can progress to sepsis like multi-organ failure. So if villi occurs, there will be worsening of oxygenation, then ARDS-like state, then multi-organ dysfunction. So the next steps we have to go is protective ventilation, which means low tidal volume, uh, keep the plateau pressure in low, and high PEEP. Then we have to make escalate to prone ventilation. Then the last step is ECMO. I'll explain about that in later slides. So next is about the basic ventilator settings. So when you put a patient on ventilator, you need to set six fundamental parameters. So you have to know these six parameters to get into these settings. So one is mode of ventilation, tidal volume, then respiratory rate, then fraction of inspired oxygen, then positive and expiratory pressure, and inspiratory and expiratory ratio. So first, the mode of ventilation, assist control or volume control. You set the tidal volume and every breath delivered as the exact volume. So this ensures reliable ventilation, but In stiff lungs, it may generate a dangerous high pressure. So in assist control pressure control, here you set the inspiratory pressure. So the tidal volume varies depending on compliances, which reduces the risk of barotrauma but can lead to inconsistent volumes. So two things: assist control volume control, assist control pressure control. In assist control volume control, you set the tidal volume. In assist control pressure control, you set the inspiratory pressure. Then tidal volume, it is 6 to 8 ml per kg. Uh, that is in ARDS, it is 6 ml per kg. Then we have to keep the low tidal volume in ARDS. Then in respiratory, then we have to maintain the respiratory rate around 12 to 16 breaths per minute. Then FiO₂ start at high, then titrate to 88 to 95 percentage. Then positive and expiratory pressure 5 centimeter H2O, higher in ARDS. Then inspiratory and expiratory ratio usually 1 is to 2. In COPD it is 1 is to 3 or 1 is to 4. So that's what I was telling the previous slide. So assist control volume control, clinician sets tidal volume. Then assist control pressure control, clinician sets inspiratory pressure. So don't get confused by this. So volume control is tidal volume, pressure control is inspiratory pressure. Next one is pressure regulated volume control. It's an hybrid mode. So ventilator adjusts pressure automatically to deliver the set of tidal volume. Pressure support ventilation, patient initiates each breath and ventilator provides assistance. So used mainly for weaning. Second, the tidal volume for most of the patients it's 6 to 8 as I said before. Third, the respiratory rate is usually set between 12 to 16 breaths per minute. Then fourth, the fraction of inspired oxygen or FiO₂ always start at high in emergencies, even at 100%, but titrate down as soon as possible. The goal is to maintain oxygen saturation around 88 to 95. So being in 100% for a prolonged time, it can lead to oxygen toxicity. Then fifth is, I told you, PEEP prevents alveolar collapse, starts at 5 centimeter water, then increase it to 8 to 15 centimeter water in ARDS for better oxygenation. Watch for hypotension due to reduced venous return. Then lastly, it's inspiratory is to expiratory ratio. Normal is 1 is to 2. In COPD, it is 1 is to 3 or 1 is to 4. Then inverse ratio ventilation for refractory hypoxemia, which is 1 is to 1, requires deep sedation. So this is the table I was explaining in shorter way. It is given in Harrison. Uh, each mode of uh, ventilatory settings like assist control, volume control, assist control, pressure control, pressure regulated volume control, pressure support. You can just take a screenshot of it so that it will be helpful. I have explained it before. Now we will go case based settings. For ARDS, the tidal volume is 6 ml per kg, respiratory rate 16 is to 20 breaths per minute, FiO₂ start 100%, then titrate it too slowly, PEEP 10 to 15 centimeter water, then plateau pressure less than 30 centimeter water. If it is not improving, then go to prone ventilation or ECMO. I'll tell about ECMO in later slides. Then in COPD, the problem is carbon dioxide clearance and airway trapping. We set the tidal volume around 6 to 8 ml per kg and respiratory rate around 10 to 12 breaths per minute. Then FiO₂ 40 to 60%. We should always avoid keeping the FiO₂ around 100%. Then PEEP, it should be also low. Then inspiratory expiratory ratio is 1:3 or 1:4. For neuromuscular weakness, it is usually the normal lungs, just weak muscles. The tidal volume is around 6 to 8 ml per kg. Respiratory rate around 12 to 16 breaths per minute. FiO₂ you can keep it at low, around 30 to 40 percentage. Then PEP around 5 centimeter water. Next, we'll see about non-invasive ventilation. There are two modes: continuous positive airway pressure, then bi-level positive airway pressure, which is called BiPAP, and other one is CPAP. So indications include COPD exacerbation, cardiogenic pulmonary edema, and some hypoxemic failures, such as immunocompromised patients or pneumonia. It is contraindicated in who inability to protect airway, like coma or seizures, severe encephalopathy, and hemodynamic instability, and high risk of aspiration or vomiting. These are the things we should contraindicate. So CPAP delivers a continuous stream of pressured air and keeps the airway open to improve ventilation and oxygenation, reduces the effort of breathing, whereas in BiPAP delivers two levels of pressure. One is IPAP during inspiration and EPAP during expiration. So assist with both inspiration and expiration, reduces CO2 retention, enhances overall ventilation efficiency. So we should also think about the weaning. Weaning is the process of transitioning from mechanical support to spontaneous breathing. We can't directly remove the ventilatory system, so it will cause a relapse of the patient. So it will worsen the case. So there are things to do before weaning. What we do is daily readiness assessment, spontaneous breathing trials, and extubation if successful. And in high risk patient we do HFNC or NIV post extubation. In failure we do in re-intubation and reassessment. So every day we must assess readiness. This includes stable hemodynamics, adequate oxygenation with FiO₂ less than 40, and PEP5, and resolution of primary illness. The most common test is the spontaneous breathing trial. There are different ways to do this. One method is T-tube trial, where the patient, I have shown in the previous slide, is the T-tube method. Um, the patient breathes spontaneously through the T-piece connected to oxygen, without ventilatory assistance, usually for 30 to 120 minutes. If they tolerate it without distress, they are ready for extubation, and that's how weaning is done. Then another method is low level pressure support ventilation, where the ventilation gives minimal assistance. So if the patient passes the trial, they can be extubated. If they are high risk, we can extubate directly to high flow nasal cannula or non-invasive ventilation. If they still fail, they should be re-intubated, and the cause for failure, it should be reassessed. So next is extracorporeal support, which is ECMO. ECMO is the highest level of support, where blood is drained and oxygenated and decarboxylated in an artificial lung and returned to the body. So there are types of ECMO, which is venous ECMO, supports the lung only and is used in severe ARDS. Veno-arterial ECMO supports both the lungs and heart and used in cardiogenic shock or cardiac arrest. And there is also extracorporeal carbon dioxide removal for refractory hypercapnia. So venous is used in ARDS refractory hypoxemia. Veno-arterial ECMO is used in cardiogenic shock. Usually you can see this veno-arterial ECMO in end stage of cardiac arrest. Uh, so they will put them in veno-arterial ECMO, and extracorporeal CO2 removal is for severe hypercapnia. So indications, it's severe ARDS, severe hypercapnia, cardiogenic shock or cardiac arrest, refractory to resuscitation. You can't use the VACEMO at the early stages. You should only use it when all the resuscitation has been failed. So limitations or complications include uh, anticoagulation like bleeding risk, infection, vascular injury, thromboembolism, then expensive. It is expensive and requires expertise and ECMO centers. So finally, to summarize, mechanical ventilation support life but must be tailored to disease. Um, so ARDS oxygenation problem, low tidal volume, high PEEP, prone if needed. COPD ventilation problem, long expiration, low rate, careful FiO₂. Neuromuscular, normal lungs, weak only weak muscles, so full support is given. Complications are preventable with vigilance. Liberation requires daily assessment, spontaneous breathing trials, and sometimes T-tube testing. ECMO is the ultimate rescue, used only in specialized centers. I told you about ECMO. Then mechanical ventilation is both science and an art, knowing when to push, when to hold back, and when to step aside and let the patient breathe again. So, so I hope this whole lecture made you confident enough for you can even go through again back your books and know more about how to set the ventilator. I have made a concise PPT on it so that you can understand more easily. So thank you and subscribe to Doctor's Desk.